So I'd like to thank the Minister of Health for his input. He's not the Minister of Disease Treatment. And I think that's an important emphasis, because I think many people, especially when we start talking about bringing down the burden of disease and measures to reduce alcohol abuse and the health consequences, people try to say, well, is that your portfolio? But I'd like to then move to invite the Minister, Professor Hsiao and Dr. Tom, to join us up front here on the panel. And there'll be an opportunity then for anyone to ask any questions you like.
Thank you very much, Chair. Yes, I'm Sam Mokgokong, the President of the Health Professions Council of Africa, of South Africa. I'm still a practicing clinician. I'm head of neurosurgery in an academic hospital that the Minister talks about. And I feel we need to comment. It's a comment, and I'll try to keep it short. From our perspective, it's a good start to go to primary health care. Now, I say it's a start because it cannot end there. It cannot end there because improvement in primary health care is going to bring about things that are unearthed that need to be dealt with at academic level. Now, at the level in South Africa, it might be scary, but we have an advantage here. Already our infrastructure is that public hospitals, academic hospitals, are actually public hospitals. I remember when we dealt with a very expensive operation in the past, and that was separation of Siamese twins. And it was in 1988 at Baragwanath. Now, Ben Carson from America, Johns Hopkins Hospital, was doing the same on the Binde twins. They were flown all over from America, from Germany, to be done there. We did these operations almost simultaneously. And I was in communication with Ben Carson. And in the end, I asked Ben Carson, how much did it cost the family? Now, he said it was 1988, about $1 million. Now, that would have been 4 million rands, because it was a 1-to-4 conversion at that time. And of course, the patients who came to our institution didn't pay a cent, because the institution was already functioning. That was Mponyana. Later, the Binde twins from Zambia came to our hospital. The twins are alive, they're separated, they're going to school now. And what was the cost? The Zambians still owe us 200,000 rands. That was the cost of many months of hospitalization and treatment, because the expertise is already there. You don't pay for it. It's already there. Now, you know, of course, the hospital authority keep telling me, look, the Zambians are still owing us 200,000 rand. And I said, don't worry, our liberation movements stayed there for many years. The long and short of it is that, Honorable Minister, it is correct to focus on public academic hospitals. We're already geared to help the poor. We're already helping them. We can help them more if you, in fact, empower us. And just finally, it is a good thing that you say, you know, the public service as one of the prerogatives. People don't understand this. They call it an absolute prerogative that you must strengthen and improve the public services. My understanding is that when the resources roll in, they must be directed towards the public service, because that's the tier that's going to bring equitable health care to everybody. We can do even the most sophisticated operations in the academic hospitals, and that's where you need to really strengthen. You're quite right. In our situation, it's the academic institutions that are training the doctors who go into private. So, I mean, the teachers of these people in glossy private sectors are actually the public academic institutions. Thank you very much. That was a comment.
Yes, well, We'll take a few comments and questions and then go back, but strong support for strengthening the public sector.
Thank you very much. My question is to the Minister.
Sorry.
Sorry.
It's Professor Jinabai?
Sorry, Professor Jinabai from, I'm a member of the ASELPH Steering Committee and also a member of the Academy for Health Leadership and Management. We applaud the Minister and the speakers on both the primary health approach. We prefer the term the public health approach, which brings to fore all the full spectrum of public health skills. And we fully support the need to build that foundation and the building blocks and build upwards from there. My question really is to also make an appeal that while we are undertaking these various executive management leadership training programs, we would like to also call upon your colleagues in the Department of Public Service to look at how we can create, from the public service perspective, career pathways and opportunities in the public sector where, for example, if there are executive fellows and people with diplomas in health services management and masters and eventually PhDs in health management and executive leadership, then sufficient career pathways exist whereby the career structure in the public service is created in such a way, the regulations, such that full recognition is given to managers and executive health leadership people such that they are able to then move from director level, district directors, program directors, all the way to CEO of hospitals, etc. So my plea and request is for us to also look at pari passu while we're doing these training programs to also create those career pathways in the public service. I'm not talking about obviously the private sector, the public service, to retain and also acknowledge and recognize these leaders. That's what the Academy is striving for, that's what ASELPH is striving for. Thank you.
Maybe I should just use the opportunity to clarify. We have with us today the chairperson of the Academy for Leadership Management in Health, Professor Marion Jacobs, and a number of members of the steering committee. The Academy is the overall body entrusted by the Minister to drive the development of leadership and management training in the country, and will provide the governance for such training. It'll accredit programs, it'll review curricula, and broadly advance leadership and management training as a whole. The ASELPH program is a provider. So we have positioned ourselves in particular to focus on advancing executive leadership and management, and we look forward to the Academy's process of creating proper structures. So we look forward to peer review, we look forward to accreditation, we look forward to review of our curriculums and programs, as I'm sure do many of our other colleagues in other health leadership and management training programs and developments. So I just wanted to maybe use that opportunity to clarify that.
Yeah, thank you very much, Chairperson. I'm Dovani Takati. I'm a professor of public management from University of Fort Hare. Oh, okay. Thank you, Minister. Firstly, I just want to acknowledge the role of the Minister in championing this new policy. But being a professor of public administration management who teaches leadership, I'm just concerned, Minister, in terms of the leaders, starting with the leaders within the health sector. You know, whether there is a bit of awareness, not awareness, but synergy in implementing this policy. I'm talking about this because, I mean, the backbone of this department is normally on the ground where people go and interact with the health institutions. So is there any strategy in terms of galvanizing, bringing all the key stakeholders together to say, let's move together and make sure that we implement this policy? Changing the organizational culture within clinics, hospitals, and going back to the basics, just going back to the basics in terms of positive attitude, in terms of taking ownerships, you know, when things are not moving. I've seen you on many occasions, you know, going back to your profession, trying to help in hospitals where there were problems. And also instilling a sense of duty, you know, starting with the cleaners and other people in the sector. And making sure that we are together here. I think if we can have this awareness and make sure that from the minister downwards, in all regions, in all departments, I mean in all provinces, if this could be taken to that level, maybe we can see some changes in certain institutions. Thank you.
How do we sell the NHI to the younger age group so that they're behind it, so as they grow up, they're going to be supporting it? You're talking about a 15-year system. They're going to be the ones who start paying for it when they grow up.
All right. So maybe what we could do is, I mean, Minister, you've had strong support for strengthening the public sector, but you've been asked about questions of implementation and marketing and how are we going to get that right. But before I ask you to talk to implementation, strengthening management and marketing, I'm going to ask Dr. Tom to comment from his perspective, how are we going to get it right in rural areas? You know, so you know, it's all good well to talk about choice in urban areas, quality in urban areas. We've got, but how are we going to get it right? And before I get to Dr. Tom, I'm going to go to Professor Hsiao and say to him that you spoke about affordability and sustainability. And one of the big challenges we have here, of course, is that ultimately you have to make a choice on a package of services and be able to say all South Africans should have equal access to this package of services. And they can go to the public or the private sector to access that. What's the global experience in keeping the package affordable? Because many people will want to get everything that modern healthcare can offer. And what would you say is the global experience? So we'll go in the reverse order. Professor Hsiao, Dr. Tom, and then the Minister.
You are talking about what benefit package do you actually design, and that's affordable. And I would like to just say, emphasizing what the minister said, not only what's affordable, but you also want to make sure the quality and availabilities are there. Otherwise, it's an empty promise. That's his point. And so therefore, countries are doing it right, like I mentioned, countries like in a similar, at a middle income or lower middle income level, like Thailand. Thailand made sure those services are there or can be made available when they put more money into the, through national health insurance, and the quality of care. So they relied on nurses. They did not promise people in the rural areas, and even in small cities, you can have access to physicians. But rather it's mostly it's nurses, nurse practitioners, and then has a team head up by physicians. So just in short, countries have actually sustained their system and gained wide popular support is made very clear to people. We are right now only promise you this much, and we will assure it's there. Then you expand, rather than trying to promise everything. And as the professor there said, you can promise people definitely double organ transplants today, heart lung transplant. And how much will that cost? But a country I like to just respond to your comment a bit is Minister of Health I dealt with around the world is always struggle with how do I provide basic services for my people equally, as the minister wants to do. Also, I keep advanced medical science. That's always a struggle. I don't have good answers, but I think that's the judgment the minister have to make.
Professor Tom. Dr. Tom? Yeah, I think you have a microphone behind you.
Is it on? Okay. Thanks, Eric. I will comment on that rural-urban issue after just two other comments that I want to make. First, in reference to the point raised by Professor Mokgokong. I normally call you Sam, so you don't mind if I say Sam. Just to say, tertiary care, secondary care, primary health care are just one system, a healthcare system in the first instance. So the issue of prevention does not just refer to the level of care in a primary health care setting. It refers to the whole sector of a national health system. And in that regard, I just want to say the secondary and the tertiary cares of level are a backup to the primary health care system. When you talk primary health care, you have to consider that and other collaboration with other sectors. So it's important to ensure that you strengthen those levels so that when that section fails, the primary health care level, there is backup to take care of those who have been failed. In this regard, I just want to quote one example of a failure of a primary health care in a rural setting, Eric, just to point the point that you are saying. You watch this television program where they call on the population to assist a particular individual who, for some reason or the other, is suffering. It was in the newspapers in the Eastern Cape on a daily dispatch. A young boy in the Bazia area of Transkei. This boy had a disfigured face. And all of a sudden, a call was there for plastic surgeons to assist this boy. Hospitals could not assist the public sector, so he was going to be referred to the private sector minister. And a call was made for funds. But this was a typical failure of our primary health care system, in the sense that this boy had been to clinics in that area with pimples in the first instance, seen by the nurses, given some creams, and sent home. And I'm not blaming the nurses, I'm not blaming anybody, I'm just trying to illustrate how things can fall apart. This young boy came back after the pimples with sores to the same clinic, was seen, treated, betadine, antibiotics, etc. After some time, this boy came with a disfigured face, and everybody was now concerned, sent to hospital. All it proved in the final analysis is that this was a skin tuberculosis, which was not picked up. And this boy ended up having that disfigured face and needing the tertiary care in plastic surgeons' hands, etc. Now, I'm saying that the basic issue of quality that the minister has raised is a very important aspect, whether you are rural or you are urban. If you address the issues of quality of care, and some of us have worked in those rural settings, and the minister himself has worked in those rural settings, offered the type of service that was required by the people. But the preventative aspects go beyond the search for care in a facility. They go to health promotion and all those aspects in the places where we live, and we need to deal with those issues. Basically, if you deal with the issues of quality, issues of equity, the issues of access to health care, rural or urban, the human resources that are required, being deployed in areas of need, making sure that people can be availed to assist in primary health care. All the issues that are now being put in place about community health workers or community developers, people who are going to be there to assist the system. Those are necessities, whether you are urban or rural, but more in need in the rural areas. Talking about NHI in the context of not addressing the three aspects that we have raised, including the 6, and in fact they are included in these 3, the 6 that the minister raised. The issue of quality, the issue of equity, the issues of access. We can never be able to deal with ill health in the country. Thanks.
Great, thanks, Minister.
Thank you, Prof. Hey, maybe let me start with this last issue. That Dr. Tom and Professor Mvuyo were debating about primary health care, tertiary versus the primary health care level. When I first met the College of Medicine in 2009, that was their fear. They said, Minister, if you say the core, because I've been saying that for a long time, the core of the healthcare system is primary health care, are you not going to kill academic medicine and tertiary services? That was their fear, that will send all the money there. And I was telling them that if primary health care doesn't exist, you are also going to collapse up there, because everything will come to you. I'm sure you are aware that your tertiary hospitals are now dealing with very ordinary things. You go to Chris Hani Baragwanath Hospital, you find everything that was supposed to have been done in a clinic, being done at the level of professor. I'm not surprised why skin TB is now solved by a plastic surgeon. At what cost? Skin TB, I'm not surprised. It's, you know, so it's clear he's right. And so I was saying they are going to help each other. And in this case, if you look at our plan in re-engineering primary healthcare system, we're trying to solve that. And I suspect, Dr. Tom, that if our re-engineering works very well, that child will be detected somewhere within that. Firstly, we have got the school health system with school health nurses. There are 12 million kids at school at any one time. Most probably that kid was going to school. Yes. But nobody picking that. Now we have got the school health system. But secondly, then you have got municipal ward-based primary health care workers. Our dream is that these primary health care workers must be given a group of families. They must know them, at least. We saw this working very well in Brazil. And I'm sure a chap like that will also be detected somewhere there. Yes. Thirdly, that's why we also introduce the principal specialist teams in the districts. Because we thought part of their job is to determine these referral methods. At what time does referral happen, etc. But lastly and very importantly, that's why now in the NHI pilot districts, we want to contract GPs to work in clinics. Even if in the clinic there's no doctor every day, but at some stage or other, maybe once a week, there must be a doctor. And my suspicion is that that child will have maybe, will have been picked up in one of these levels. That's why it's so important. I don't think you'll have gone through all these levels. If it happened, it will be very rare. But at the moment, what you're saying is not very rare. It's what happens every day. By the time they arrive at your level, Prof, it's always worse. By the time they arrive at your level, it's always at the, it's always at the end of the disease. Like when I grew up, when there were no doctors in rural areas, we used to know about this Baragwanath. And people hated it with all their heart. Yes. Because they will tell you, if you say you are sending a relative to Baragwanath, they start crying. Really. Because they said nobody comes back from there. Never. But what was the reason was that we're sending people to die, end stage of cancer at all the time. Nothing having happened at primary health care. Once it's at end stage, we say Baragwanath. Of course, later on, in the case of Limpopo, it came to be represented by George Mukhari, Metunsa, Once you mention that, they say it's death now. I used to work in Bushbuck Ridge where relatives will come literally plead with you not to send their relative to George Mukari because they said they'll never come back. You know. Nobody came back from there. Yes, it's because everybody who was going there was end stage. We're not just allowing them to die there in rural areas. We're saying they must go there. You professors will see how to wake them up from the deathbed. That was the belief. So we want to relieve you from that. Can it start happening at the primary health care level? And only those who have to come to you. Only. Yes. I think that's the first thing we want to do. Secondly, this South African health model which started with specialists, because GPs are getting annihilated out of this system. There are no more GPs here. That's why I want to bring them in. Yes. So that issue of a plastic surgeon, I was giving an example about it. It happens every day in South Africa. You can have a housewife using a knife in a kitchen, you know, to peel fruit, get a small cut. I can tell you they are going to end with a plastic surgeon immediately. And imagine calculate. No, they are going to. They are going to. I was approached just 2 months after I was appointed by a local businessman in Limpopo who heard that I'm back home. He came to complain to me. He said, Minister, tell me what has changed in the healthcare system. By the way, some of the things we are bringing used to be there in the past. He said, look, I was cut by a knife when I was working. He's doing a lot of manual work. He said, I went to a clinic. In the past, the nurse will have put 3 stitches in the past. He said, but now they send me to a hospital where I waited for 10 hours. That's what he told me. And he said, Minister, I'm self-employed. I can't afford 10 hours out of work. Can you explain to me what has changed? Why couldn't the nurse just put 3 stitches on this small cut like they used to do in the past? In other words, you are showing that the system at the bottom has died. It's now at the top. With plastic. Now that's the system we need to end. Professor Paradi, we are actually doing that. The NCOP has just passed a law last week. The president is going to sign it to establish the Office of Health Standard Compliance. Yesterday in the speech, I didn't speak about it. The DG kept on sending me a note. She was very worried because she said people won't understand that we want to start here. The quality. In other words, we want the special office that will impose this quality, these basic standards we are talking about, of cleanliness, of infection control, of attitude of staff, of security of staff and patient, of waiting times, and of drug stock outs. By the way, South Africa health clinics, they run out of drugs when we have got a lot of money on top there. But at the bottom, yes, this drug stock house has got nothing to do with the budget. That I can assure you. It's just how the system is run. So we are going to have that. But before even the inspectors come, we have established what we call FITS. FITS, Facility Improvement Teams. Because these 6 standards, we had an audit to measure them. We now know for every hospital in the country. Every. And clinic, by the way, yes, and clinic, Deputy Minister, you're right. All 4,200 of them. We all know what each has got on the 6 basic standards, on cleanliness, infection control, waiting times, drug stock outs, safety and security of staff, patient, and attitude of staff. And the results are scary. On 2 standards, 2, cleanliness and attitude, there's 80% failure rate on cleanliness and attitude. And I was saying the CEOs when they were training, to me, if the attitude of staff is negative, it's a reflection on the leader of that institution. If the CEO is not well trained, that attitude is not going to change, no matter how many more policies we put here. So this issue of basic standards, we are going to have to deal with that very well. And then, is it Professor John Mitchell from Fort Hare? Yes, yes. The failure of your son in the debate. I know why he has failed, you know. Everybody else will fail. Yeah. People are not convinced about NHI because the manner in which it came in 2009, it was debated. It came to them as we are intending to destroy the efficient, good quality private healthcare sector, replace them with the inefficient, poor quality public sector. That is their understanding. And as long as it comes to them like that, there is no debate will win. So my feeling is that we don't even have to market NHI, honestly, as far as I'm concerned. It doesn't need any marketing. In the traditional marketing techniques, that's what I'm saying. The best marketing for NHI is just to improve these basic standards and quality. Yes, just go to a rural hospital with this audit as the DG has done, the facility improvement team. Let them see the cleanliness improving. Let them see the hospital maintained. Reduce the waiting hours. Don't run out of drugs. Let the attitude change. Let them feel very safe. Once they do so, tell them it's NHI. You have marketed, you have won the market. Yes, tell them, you see what you are seeing, this is NHI now. Nobody will ever convince them otherwise, because that's the problem that they are faced with. At the moment, people don't know that. Yes, I think it's very important that that happens. It's not difficult. We have already had before and after stories, by the way, on these facility improvement teams. One of the things I don't understand, even cleanliness, you know, because the facility improvement team come from head office. Why leaders in an institution could wait for us to tell them to clean a hospital? It beats me, but they found it. And they say, no, here you don't need money, just cleaning. And many people are starting to get convinced that they need more money every time there's a problem. It's not a question of money in all these things. Yeah, it's just that's why the leadership is so important. Yes. That you are going to teach them that every day this is what you must do, these are the standards. And then we'll have a lot of before and after stories, then we'll win the battle. Thank you.
Thanks, Minister. I know you, some people wanted to clap for you there. I interrupted. Minister, I know that you have another appointment waiting, but I've been told that I'm allowed one more round of questions. You've given us the whole morning already. So we can take a couple of last questions and then quick replies. So here we are. Let's take, and then there's a hand at the back, and then
Do I start or
Dr. Kislasamy in the corner.
Oh, okay. Thank you very much. My name is Claudia Shilumani, and I'm the Director for Health System Strengthening within ITEC South Africa. It's an honor for me to be in this audience, and I really appreciate what the Minister has said and what everybody else has said. Now, I want to follow up on what the Minister has just said. It's one thing to develop basic standards and also do facility improvement assessments and sort of give them the guidelines in terms of what they need to do. But I think the problem you're sitting with is the performance management within government, because the people that are working in the public sector are not able to do the job to the certain quality that you desire of them to do. And what we're sitting with is, instead of firing them or making them face consequences for it, we're sitting with the unions, trying to negotiate them back into their jobs, because that relationship there with the unions is very much undesirable. So in my view, I'm saying, in addition to developing the basic standards and sort of giving them guidance in terms of what they need to do, we need to strengthen the performance management system so that if people are not doing what they're required to do to the quality that is expected, they should be fired. I mean, in the private sector, that's what happens. Okay. That's why a lot of people prefer the private sector, because they know that when you go there, if you're not treated right and there's a complaint, somebody does get fired. Okay, but in government, it rarely happens.
All right, thanks. If we can just keep the questions or comments very short because of time. And then, Tanya, Dr. Kislasamy is waiting for the corner.
Okay, good afternoon. My name is Noluthando Madu. I'm from the Industrial Development Corporation in the CSI unit, Corporate Social Investment. Thank you for this opportunity to the panel. I think what I'd like to ask Minister is that what type of interventions and collaboration are you looking for from the corporates, parastatals, and the NGO in complementing this policy, the NHI policy? Thank you.
Right, quick and clear. Kislasamy, can you be as quick and clear as that?
Minister and panel, I think one thing that was missing, Minister, and the panel members, was the direct control that you've exercised over the Ministry of Health, that you've pulled together. My concern is the indirect processes of the intersectoral linkages. Right now we're going to the winter season. A whole lot of informal settlements will have shack fires. And people will come into us with burn injuries or they will die. Food security you've tried to sort out through provisions for salt reduction and things like that. But if we don't deal with the outside areas on food security issues through agriculture and farming. Occupational health, fortunately, you've brought some of us in, and we're going to retool that to sort out TB in mining, injuries in this sector, etc. What do we do about the intersectoral issues on preventing the consequences of poor practices, like Bangladesh that took place 2 weeks ago, with 1,200 workers now dead, many others injured? Intersectoral collaboration, how do we deal with that and the consequences for the health sector?
Okay, great, thanks very much. So Minister, you're the most popular panelist. But I think there are three questions that are coming to you. The first one is, how are we going to strengthen management, for example, at the district level? How are you going to do it, creating career paths, better management, change management, performance management? That's the one cluster of questions that has come out. The second one is the role of parastatals and civil society in advancing strengthening of the health system, and the question about intersectoral collaboration. I presume agriculture, roads, education, and all the other factors that impact on health, water, pollution, and so on. I'm not going to tell you how long you have to reply.
Yeah.
I know your staff are anxious.
Yeah. I'm not the most popular panelist. I'm the most guilty one. That's why all the questions are coming to me. I'm the guilty one here. Yeah. Let me start at the bottom with Barry's question, the intersectoral collaboration. I think it's not only in South Africa. Last year, was it 2011, the World Health Organization called that meeting in Brazil about social determinants of health. We just have to take, we just have to take that document about social determinants of health and see what countries need to do. And I don't think there's an argument, even here in the government here in South Africa, in our own government. The question is how to do it and whether we're going to get time to do it. Take, for instance, the negotiated service delivery agreement, increasing life expectancy, maternal and child mortality, TB and HIV, and strengthening the health system effectiveness. When I signed with the president, when we signed, they then said every minister must choose other ministers who impact on your job and sign agreements with them. And we did. We did. I still remember it happened in the Department of Health where I called all the ministers who impact, and we signed with the MECs first, then I signed with the minister, water affairs, energy, because they have to provide electricity, agriculture, and all that. They all signed, and that was the last time we met, unfortunately. Unfortunately, yes. Because now, each one of them is engaged in their work. And when you call them all the time, it will look like they are running health. Yes, they complain. Like, look at SANAC, HIV/AIDS, because we said it's such a big problem. There are many ministers who are in SANAC. It's chaired by the deputy president. Many of them believe, look, we have done enough for health, man. Yes, they believe they've done enough. We've got our problems too. So it's not that they are refusing, it's just that the concept is there, but it's very difficult. But we'll keep on trying. They also discuss it at the Forum of DGs, FOSAT, where the DGs meet. They discuss all this collaboration. So they are there in line. The issue of management. There's a belief in South Africa that public servants never get fired, you know, because of the constitution and the law. It's not true. It's only that before the elections, during the time of apartheid, it was very easy to fire anybody if you like. You didn't have to follow any law. You just had to look at them. If you hate them, they are gone. And that was happening to many black people. I think you must understand. It's like the death penalty. People don't understand where ANC is coming from. It was very easy to be hanged. Yes, and you know that President Mandela and them were nearly hanged if the international community didn't complain. So obviously when you come into power, you stop that. So we also stopped that. just easily firing people without any processes. And processes were drawn up. South Africans are not used to them. They believe, no, it's the law not to fire. Those of us who know these processes have fired many people, by the way. Yes, we can. It all depends who is managing what they want to do. The laws are there, you do fire. And I'm not joking, you can ask the DG, she'll give you the list of people who were fired in the department since 2009. You just sign there after the process and they are gone. There are many, but they still believe that no, we don't fire. I don't actually understand where it comes from. But it's because we're strengthening not to make it very easy, but we can train our people in those issues of performance management. The role of parastatal civil society and in collaboration, I think the roles have already been drawn up for everybody. For instance, the corporate sector, we've already met with them many times to establish this public health investment fund. And I believe, yes, oh yeah, here. This was corporate, yes. Did you see this? We'll come over this. That's when we're launching our cooperation with the corporate sector. 23 CEOs in private hospitals, medical aid schemes, pharmaceutical, because I told them, every time we're meeting, Professor, we're fighting about NHI, we're debating. I told them, can we stop this debate and do something that is common amongst them? And what is common? To help build the human resources in the country and fight HIV/AIDS. I told them, whether you are running a private hospital, a pharmaceutical company, or you are selling equipment in health, etc., you do need human resources. Why can't you deal with that? That's when we launched this public health enhancement fund. So we are cooperating with them at that level. But where will they come in again in the corporate sector? The institute, yeah, the academy, sorry, not the institute, the Academy of Health and Leadership Management will find who they need at any one time. In fact, when they were training, the DG was telling me they brought somebody from the hotel industry to tell the CEOs, why is hotel linen every day clean? We have never found dirty linen in any hotel. But why do we find that in a hospital? What are the hotels doing which we can't do in a public hospital? And that's why they called somebody from there to give them. That's why we see the role of the corporate sector, to come and give us the skills and sometimes even sponsor them, like this academy is doing. Civil society, I don't have to tell them, they know a lot. If you want to know what civil society does in health, just go to a SANAC meeting, South African National AIDS Council, you see the role of civil society there. Yes. Yes, you'll see it. Yeah. Thank you.
All right. Thanks very much, Minister. There are just two quick things left. The one is that in your packages earlier, you'll find at the back an evaluation form. Amongst the things that happen is we're very strictly evaluated in terms of our funders. So if you could fill that in. And then I'm going to, I think the Minister is going to dash, but I'm just going to give my colleague, Professor Stephen Hendricks, just 2 minutes to do a vote of thanks. He is the Program Manager of ASELPH. And then we'll end, and then, of course, everyone is invited to lunch downstairs.
While doing that, can I go there?
Yeah.
Thank you. Sorry.
Thank you very much. We just a quick vote of thanks, which we'll do very quickly. We'd like to thank Tumi and Duma for representing the family. We'd also like to thank the Director General Motsaoledi, who's here, gracing us with her presence. We'd like to thank Ms. V. Palmer in her absence. We'd like to thank our funders, represented by Benedict, Zola, and for coming and providing the funds. Professor Tyron Pretorius, University of Pretoria, we'd like to thank you to being here. We also like to thank Prof. Hsiao, who remind us of the 4 points. The insurance coverage is not effective coverage. The Miss-Barkian model, look out for that. The privatization and also the stage-by-stage approach. We also like to thank our program director, Professor Eric Buch. We'd like to thank all the participants for your participation. Then we'd like to thank Dr. Mvuyo Tom for the way you've taken us forward. Professor Hsiao, I've thanked him. Then also to thank the Deputy Minister, who reminded us of the fortitude of the Minister And that is exemplified in what the Minister said, raising the issue of cost of health care and the quality of care. And he raised the 4 thrusts of the WHO director in Afro, strengthening the capacity, raising sufficient resources, the removal of financial risks, as well as the promoting efficiency in NHS. And we as South Africans are very keen to raise acronyms. So as I was sitting there, I was thinking of what acronym, with the Minister's permission, we could leave here. And the acronym I'd like to leave with you is called MECRAGAS. MECRAGAS. What does MECRAGAS stand for? MECRAGAS, M-E-C-R-A-G-A-S, MECRAGAS. M stands for Motsaoledi. E-C for every citizen. R for the rights. A for access. G for good quality. A for affordable for the country. And S for should not depend on socioeconomic status to get services. If you get anything today, remember MECRAGAS. I thank you.